I can go ahead and begin.
Karline, I have to first go, let's get the people through. Wait a second. Okay, so welcome to the Virtual International Day of the Midwife. We would like to acknowledge University College of Lillebælt, Denmark Association of Radical Midwives. You can turn on the audio setup wizard by clicking on the audio symbol. You can use the chat room for these public chats, but please don't do private chats. You can always do a private chat by clicking on a name. You can give us feedback if you click on the symbol of the man raising the hand. You can see the drop-down menu and choose the appropriate option. And you can also write questions in the chat box or comments, but please know that we will record this and also that we plan to analyze it, though we won't link it to your name. If you want to speak and ask a question, we can enable your microphone, so you just raise your hand. There you can connect your microphone on the microphone symbol on the top. You can click on it and you can say allow, and then the microphone will start. Then you can also turn up the volume. And yes, we've started. And welcome to Karline. Let me introduce her first a bit. Karline Wilson-Mitchell, she has practiced midwifery in the US and in Canada since 1992. And she has also taught in midwifery midwifery education program at Ryerson University since 2008. She's the member of the American College of Nurse Midwives, and they're specifically active in the Division of Global Health and Midwives of Color Committee. So welcome, Karline. Great you could make it. Over to you. You can mute your microphone. Okay.
Thank you so much. Appreciate that. Thank you so much. It's a pleasure to be with you today. What I'm sharing with you are the preliminary findings of my doctoral research that is in the global health area, looking at respectful maternity care. And of course, that's the buzzword for all of us worldwide, not only in the low resource countries, but also in high resource and middle income countries. So I'm pleased to share with you one of the areas that was the focus of a recent pilot, looking at childbirth, sexual and reproductive health rights of adolescent mothers in the Caribbean, and we are going to launch this pilot to begin our research looking at several other countries, 7 countries in Central America. And I'm very grateful to those who partnered with me, my collaborators, which included the University of Technology, the Ministry of Health, and the organizations that I currently work with to do volunteer work in the Caribbean, Footprints Foundation. So I'd like us to just pause and look at the definition of the midwife according to the ICM. And I'll have everybody read this to themselves and just ponder it. Does everyone feel comfortable that they have now read the definition, recall this definition? It's familiar to everyone, and you can use your check marks to say yes, you've finished reading it. And the check marks are found up at the top where the little person is, where if you wanted to raise your hand, you could raise your hand. Okay, it seems as though most have read this and understand that we have a scope to practice both in the home and outside of the home, and in a hospital setting, outside of the hospital setting. It is holistic care. It is really to be an advocate for our clients. Our scope includes normal birth, assessment and detection of risk factors. We are very much concerned about counseling, education, and providing access. Okay. So what I noticed as I'm looking at how we measure health status and how we measure whether we're reaching our goals that the World Health Organization has set for us. Now we're post-millennium development goals, we're into the sustainable goals of the future. There's some indices that we like to use, such as our life expectancy of a particular country, the maternal mortality rate, newborn mortality rate, infant mortality rate, and we might even look at the gross, the GDP for that country and just understand a little bit more about economically how well that country is faring off. All of those things are interrelated. And if you notice the links at the bottom, I'm noticing that some of our terminology might be outdated and in fact very disempowering. Rather than using the term developed versus developing country, you'll notice I'll be using low, middle, high income countries or low resource countries, because within any one country, for instance, Canada, Australia, New Zealand, that are considered high income countries, we will see so much health disparity within those countries that there's a layering effect of those who are healthier, have more access to economic development, resources, education, choices, and those who have less access to choices. But we know that overall, in general, as we increase the access to reproductive choices and we have access to the SDHs, the social determinants of health, and the resources in the community, life expectancy of infants, mothers, and the whole population in general will go up. I'm not able to, with the technology here in Adobe, to be able to show you what is on those websites that I gave you the links for, but I'm certainly going to make those links available to everybody, and you can search for these kinds of indices yourself. I'll just place the link in the chat bar for everybody. Hans Rosling is a physician and also a statistician and researcher who has actually developed a lot of interactive open access tools for us to look at how over time you're looking at low resource to middle resource to high resource countries, that access to choice and access to the social determinants of health improves life expectancy, improves our indices such as maternal mortality and newborn mortality over time. And even if we were looking to the Americas, which is the region that I am part of, and we look at the Caribbean, we look at Latin American countries, we can see that within each country, there's a layered effect of those who have greater access to resources, have better mortality rates for their infants compared to those who have less resources. Even within countries that start off very similarly, as the GDP for the whole, the gross domestic product increases for the whole country or regions within the country, we see that layering effect for mortality as well. And we can look at various countries around the world that sometimes having access is not enough. There also has to be some social justice advocacy. So human development is all about expanding choices, as Hans Rosling discusses, and many of our epidemiologists and population studies describe that these kind of issues are relevant in terms of health. So health is more than just clinical health, but social health as well. So I'll just, you'll notice that as you go from education increasing and income increasing, health increases over time. And that's basically what those graphs are showing. Also, what I've noticed is, in terms of midwifery, quality care for us means respectful care. And the World Health Organization recently published in 2015 in October a set of actual definitions by which we can measure respectful care or criteria to decide whether respectful care is happening. So instead of using nebulous kind of subjective descriptions, we actually have these criteria now. One of the 8 criteria is that quality care also means respectful care that upholds sexual and reproductive health rights. And adolescent mothers around the world, not just in Jamaica and the Caribbean, but around the world, have been reporting that they don't feel welcomed. They feel that there are disrespectful attitudes perpetrated on them by their maternity care providers. And I was curious because I was caring for some of these adolescents who actually emigrated as refugee claimants into Canada and the United States. And it encouraged me to look deeper and find out where they're coming from, why were they fleeing some of the violence and discrimination that they claimed. So we find that Jamaican adolescent mothers, similar to their counterparts in the rest of the developing world, are vulnerable by virtue of their social status, by virtue of their clinical presenting factors. Some of them don't have access to care early enough, and they develop complications during pregnancy, and they're not managed until it's, really full-blown complications. They've described disrespectful care in their experiences in the studies in Africa, in South Asia, and in my study published in 2014 in Jamaica. There are very few studies that have come out of the Caribbean. Unfortunately, there's a growing movement now and growing studies. So this is an area that's just emerging. Midwifery education in most of our countries that are low-resource countries tends to focus on clinical care. We've just begun in Jamaica to start including ethical care and ethics and decision-making and consent into the curriculum, but it has not been traditionally the case, and the majority of the midwives have not received that kind of content in their education. There was no literature that described the opinions and perspectives of the midwives and perinatal nurses who work in Latin American and Caribbean countries regarding what they felt were the barriers to provision of respectful quality maternity care. So that was the problem I realized I was facing. Before I could even start to look at quality improvement, I needed to find out where the midwives were. And so that brought me to this study. My purpose was to learn what hinders the nurses and midwives who care for adolescent mothers from having this aspect of respectful care, which means the right to have informed consent, shared decision-making, confidentiality, and the right to have a companion in labor according to the World Health Organization definition of quality care and respectful care. So when I reviewed the literature, I found that there was a growing amount of literature that described respectful care the way the World Health Organization described it, and certainly this seminal paper that came out by the World Health Organization with their charter in 2015. And there were a few studies that started to look at Africa and South Asia and a little bit in the Caribbean specifically. Dr. Joyce Roberts co-authored a paper that was just published a couple of months ago that looks at 7 different countries in Latin America. So these are just growing studies. We find that disrespectful care by maternal care providers does occur in low-resource countries, and we see it in the Dominican Republic, in Bolivia, Chile, Colombia, Guatemala, Honduras, Panama, Peru, and Guyana, and in other parts of the global south. As I mentioned before, we see it in India, Kenya, Peru, Burundi, Nigeria, and Tanzania, where I have visited. Interventions such as deploying community workers who are skilled in cultural sensitivity and respectful communication strategies might improve maternal satisfaction and encourage them to use the service earlier in the pregnancy and earlier in labor, and also tends to improve the perinatal outcomes. We've noticed that also when we talk to the midwives, they describe challenging shortages of equipment and staff. They also describe job dissatisfaction, low morale or motivation, and a significant desire to quit the job. They also describe inadequate training. They also noticed in the studies, Boren noticed, that there's weak infrastructure, and this seems to discourage respectful care. There are higher numbers of maternal mortality and newborn mortality rates. In the higher resource countries, by contrast, midwives describe the internal challenges to providing care, just the social dissonance and finding it challenging because their own personal morals are so divergent and different from their clients. But their challenges are not so much with infrastructure and resources, it's more of the relationship. There is very little describing the relationship that midwives have in the Caribbean and Latin America with their clients. Overall, we've seen in the Scandinavian countries that midwives are aware of the stigma experienced by adolescent mothers and feel a desire to be advocates for them in the literature. Now, the mothers' perspectives are that they tend to avoid the care from caregivers and even will have an unsafe, unattended birth in their community because of the disrespectful care they have received themselves or their family members or friends or relatives have received. They often describe that they desire informed consent, but it was not given to them. and then the providers fail to include them in the decision-making surrounding their admission and details of the plan of the care. So consequently, they have very little understanding of why they have the interventions that they have. This is very concerning because some of the interventions are very invasive. They could range anywhere from an episiotomy to a cesarean section. In fact, some of the mothers described that after they experienced a stillbirth, they were told it was their fault. They weren't told what the circumstances were. And when you read through the chart reviews, you find out that either it was an infrastructure problem, lack of equipment, lack of training. There was, maybe incompetency of the provider. But there certainly shouldn't have been blame cast on the mother. So this is a very oppressive, challenging situation for many of these mothers. They describe that there's violation to their privacy, both in terms of their physical modesty and also personal information that should have been kept confidential was not kept confidential. They also describe a desire to have a known care companion and present to give them support in labor, and either because of the constrictions of the space, certainly that's the case in one of the hospitals in Jamaica, or because of very restrictive institutional policies. They're not allowed to have what the World Health Organization says is one of the key components of respectful care. In the Jamaican study I did, this is an English-speaking Caribbean country, post-slavery, post-colonialism, very patriarchal, so there's male dominance there. We jokingly say that the male is usually the head of the household, but the woman is the neck that turns the head. That's just an inside joke. It's very stratified in terms of status, and it's based on education, socioeconomic level in Jamaica. There's a lot of stigmatization of teen pregnancy, even though 18% of pregnancies and births in Jamaica are to teen mothers. That has increased and then gradually decreased over time. We now have a 72 per 1,000 birth rate for teens, as opposed to 135, the way it is in Tanzania and the way it still is in the Dominican Republic. We have a Ministry of Health, which is a major employer, and it is a two-tiered hierarchical healthcare system in which you can pay for private care if you are privileged, or the majority of the care by far is delivered in the public sector. They really prioritize power, performance, and they really are adverse to risk and really want to make sure that you follow the policies, just the feeling of safety that that provides. When I was looking at respectful care, quality care, which are hard to deconstruct, they're both tied together very closely, that respectful care is tied to quality outcomes and quality improvement. I looked at the cost to the community versus the benefit, and we know that each adolescent costs taxpayers in the Caribbean and Latin American countries, according to one leader, $2,000 per year, which ends up being 12.3% of the gross domestic product. And so Jamaica loses, if you consider dailies as disability adjusted life years, the amount of disability cost to the mother or to a newborn that's maybe born prematurely and is disabled, it ends up being substantial, over $21,000 per birth that is experienced without evidence-based management. But managing the teens' deficits, encouraging them and engaging them in the healthcare system, allowing them to have care early, maintain a close relationship so that they can have quality care, can prevent preterm labor, gestational hypertension, and certainly in Jamaica, one of the challenges is the complications of sickle cell disease and crisis. So in the Latin American countries, many of them are democratic. There's not as much civil unrest and war as there might be in other countries. Jamaica in particular is a low to middle income. It's a middle income country. Most of the countries in my study will be low to middle income. Nursing and midwifery has had some challenges with their autonomy, and scope of practice has been restricted, and there is some retention issues because of job dissatisfaction. The Ministry of Health, as I mentioned, is the one that is the major employer and actually dictates the policy in most of the clinics in Jamaica, both private and public. There is a policy to treat teenagers as high risk, which means that they cannot deliver in the community. They have to go to a high risk tertiary center, what they call Class A in Jamaica. In North America, we call that a level 3 hospital. So they often do not deliver with a known provider and someone who they trust, like the midwife. Thank you, Mihaela. I've got 12 minutes apparently. adolescent pregnancy is high risk, and the emancipated minor law allows them only to make decisions if they're 16 and over for themselves and their infants, so they're not able to have informed consent. I used Denzin's theory of interactive interactionism to look at this, and the perspective I used of the power imbalances, the fact that it's a female-dominated profession, and there's a tug of war between the needs of the midwife and the needs of the client. If you look at the society in Jamaica, there are symbolic interactions between the family members and the mothers and the clients, the Ministry of Health, which is a major employer, your peers, which are other midwives who are members possibly of the Midwifery Association, and where you may get solidarity, the council, which is your regulating body, the community, and midwives are very key members of their communities and change agents. I used a generic qualitative methodology and got consent in order to do focus groups, which I conducted in August of 2015. There were some challenges with the language because even though it's English, it is a dialect, and many symbolisms of words such as choice mean different things in Jamaica. However, the key points were that I was looking for what are their perceptions of their role as a midwife, what are their opinions about informed consent regardless of the age of this adolescent, thoughts about shared decision-making with this mother, and about having a support person accompany that person during their labor, and thoughts surrounding privacy. The average midwife that I interviewed 12 midwives. The average was 41 years old, but they ranged anywhere from 34 to 58, ranges of anywhere from 1 to 36 years of practice. Education was either a 4 to 5 year post-nursing baccalaureate degree specializing in midwifery, or a 2-year diploma direct entry midwifery program that was primarily the community midwives who did home births. And the nurse midwives tended to, by and large, attend hospital-based births. They saw an average of 1 to 5 adolescents per week for care, which made them eligible for the study. They saw their roles as advocates, educators, expert helpers, activists, workers, and some of the quotations you see, recognizing we're the only one who will be able to reach the unreachable. And the laws are only, they're on paper, but the need is there. So it can be done. If it can be done, it should be done to assist these individuals. But the impact of culture really prevented them sometimes from fulfilling their goal of providing respectful care because of the patriarchism, because of the restrictions within their culture, within their religion, some of their own value systems. In our framework, our local Jamaican framework, we oftentimes find that adolescents are also deprived of certain informed choices because of local cultural, moral, and also religious beliefs. And these are barriers to the healthcare provider to provide what we're given to offer. They're basically like children, really, and we feel a bit like they're in a vulnerable position. The third thing that really influenced whether respectful care was completed or not was the paternalistic kind of ethical framework that healthcare is usually delivered in, where the adult, the healthcare provider, someone in power, makes decisions for the patient. And that doesn't necessarily jive with the International Confederation of the Midwife definition of midwifery, where this is an informed decision-making partnership. So the midwives talked about the system, the rules, the policies, having to bend the rules, and how badly they felt that the clients felt that they were wicked nurses or wicked midwives because they were not there to support them the way they wanted to be supported. And so it felt as though both mother and midwife were constrained by the same rules and policies and culture, but if they were in a home birth, out in the community, they felt less constrained. There was more room to provide respectful care. So these are the preliminary results of just 12 midwives and 2 focus groups. Respectful care was influenced by policies and culture and by the place of birth and the place where they were working. I plan on doing some continuing education and advocacy and building up capacity of the midwives. I'm already involved in some continuing education modules, and we are very grateful that there are so many resources now available to us in the community. The White Ribbon Alliance has all these resources. JAPIGO has all these resources available to us to be able to provide quality, respectful care, and how to infuse that into curriculum, how to infuse it into continuing education, and how to teach midwives how to be change agents and politically supported to make those kind of decisions for their clients and to promote their clients' rights. Any questions? I notice that I'm out of time, but if you have any questions, I would love to entertain them. Andrea, do you have a question?
Yeah, it's up since a while, so I'm not sure.
I've given Andrea the mic if she wishes to speak.
Yeah, Andrea. Andrea, let me give you the mic. Andrea, you can speak. The mic is on.
You have to press the microphone so that it goes from gray to a green color, and when it's active, you'll see little rings coming from it. Or you can type your question or comment in the chat bar. And so how many people have seen violations of those 4 criteria that I talked about for sexual and reproductive rights, such as privacy, being allowed to have a desired support person accompany you at birth, decision-making, consent. And the decision-making and consent sometimes are blurred. So I have some hands up. You have seen it. How many people are in high-resource countries who have noticed these kind of things? Because I have practiced in Canada and the United States, and I have noticed these things as well.
So, Bethany, I've given you the microphone. You want to start? You can click on the microphone symbol on top, and then you can ask your question.
I think they're all being shy as usual. The questions will come in the box.
I would like to know if you see a relationship between these power. You talked about the disempowered women in a way, and also I hear that also if midwives are disempowered, women are disempowered, there's a relationship between the two. Do you come across that in your research?
I certainly have, and the study that made me want to use the symbolic reactionism that's described by Denzen and then some researchers in New Zealand, that's why I liked this model, because it does talk about the fact that from a feminist point of view, you have a predominantly female-dominated profession who are trying to be advocates for mothers who are primarily female, and they're both being oppressed in the same paternalistic and patriarchal culture. So there are various layers of oppression, and an oppressed midwife might end up becoming a perpetrator of oppression themselves, unwittingly. My idea is to support the midwife, and if we empower the midwife, we can empower the mothers.
Yes.
The reason why I really felt strongly about doing this study was because some of the studies that came out of the Lancet series told us that disrespectful and abusive care was going on. Physical abuse, people being slapped, hit, shouted at, called names, even sexually abused and raped, and all these things are going on worldwide. I was concerned about the environment and the atmosphere that breeds this kind of behavior. And I didn't want to blame the midwives. I wanted to find out what are the things that both the midwives and the clients are experiencing, because we haven't really heard the voices of the midwives. We've seen more of the clinical outcomes and the deaths and the complications, and we see the lack of resources, but we haven't heard the voices of the midwives, and that's what I was concerned about.
Yeah, it's great, and people are mentioning that disrespectful care has come up several times. I noticed that too. There are several sessions where this is mentioned. It's kind of that there's a structural violence which is affecting both the midwife and the client, isn't it?
Exactly right. And the team that I'm now a part of, the Ryerson University Rights of Youth and Children Partnership, is partnering with Honduras, Guatemala, Dominican Republic, Nicaragua, Trinidad, Jamaica, and Canadian researchers and policymakers, NGOs, we're all looking at what are some of the structural violence elements in each one of our institutions. So healthcare, education, judicial system, media, what are some of the structural discrimination elements that are there within each of these systems that perpetuate some of this oppression and cause what's called structural violence, or social justice violations is another way some people put it. And it's based on Margaret Whitehead's research.
Yeah, the way it's a gender-based violence issue as well, isn't it? Because the midwife is usually a female care provider and the women, and it's that component too, I assume. Huh?
I certainly agree. And some of our comments in the chat bar have been excellent. Thank you, everyone, for sharing your resources and thoughts. And it seems unbelievable, for instance, that someone who has been abused could become an abuser, but we see it in childhood abuse and we see it in situations where there's intimate partner violence. We see other areas in social sciences where abuse happens and the victim then becomes an abuser. So I'm not surprised that we see it in healthcare. I don't want to make light of it. I think we all need to be responsible to give respectful care, and we can't make excuses, but I do believe a lot of education, support, and capacity building is necessary. And I want to avoid blaming, and I want to instead support and empower.
I think that's an excellent sentence at the end. We want to empower women and midwives and yeah, to have better outcomes and more satisfied people around us, I guess. So let's wrap up. Thank you so much, Karline. That was really, really interesting, and we really appreciate that you are there for your for the women you take care, and I hope you have maybe a good birth in the afternoon. I don't know what's coming up, and thank you all for listening. We will close that. We stop the recording now.